All right, Andy, we ready?
Sure, let's get started.
Well, welcome everyone. Thanks for coming tonight to listen in and participate in tonight's case study. I'm Glenn Galton, the director of the Center for Global Health at the University of Pennsylvania, and the lead, because of my role in the center, Penn's lead representative to our relationships in Guatemala. And those relationships are very deep and very broad. We worked for a very long time with UFM, and from last week, those who were fortunate enough to listen in last week a little bit about the relationship from Dr. Sergio Martinez, my counterpart down at UFM. We also work with one of the the largest public institution in Guatemala, USAC. And between the two institutions in Penn, we forged a very long lasting and impactful relationship. It's sort of one of the, among the many bad things that have happened in the pandemic, one of the casualties, unfortunately, has been an expansion and a retooling of our relationship there. We actually began last fall thinking about ways to think of a new version of our strategic plan and working with both UFM and USAC in Guatemala. And we were all set to come down and launch things, and in like February and March. And February came, and we were really planning to go. And then in March, everything got halted. So hopefully, in the not too distant future, we'll be down and think about new versions of what we can do together. But in the meanwhile, Sergio and I had been strategizing with Andy and others, both at Penn and at UFM, about ways to connect the institutions in more intimate ways, and ways that so we thought we'd try what we experienced in the last session and tonight, which is bringing the students together. And we know, for at least for a period of time, the UFM students were prohibited from patient contact. It was a little true at Penn, of course, as well, although we came back a little faster than they did. So I want to thank everybody, particularly the organizers, Maria, Dohan, David, Sebastian, and Jay, for leading tonight's discussion. They've spent extra time doing this. Wish you all well. We would like to continue this at some frequency in the future if it's beneficial and fun for you guys, but only if that's the case. We don't want to force any of these kinds of relationships. So thanks, everybody, and particularly thanks to our organizers tonight. So Andy, I'll turn it over to you and everybody else, and I'll be listening in. I know absolutely nothing about pediatrics, so I won't be able to contribute very much, but I'll certainly be listening, and thanks again.
Thanks, Glenn. And our first group, you can go ahead and go off mute and share your screen.
All right, great. My name is David. I'm currently a third-year med student at Penn.
And hi, everyone. My name is Dohan. I'm a last-year medical student here at the University of Francisco Marroquín.
Great. And today we're going to kind of present a curious case of back pain to you guys. And I actually sent a link in the chat. We're trying something new here today. It's a link to a Google Jamboard. You don't need to click into it now, but when we get to kind of coming up with a differential diagnosis for our case later on in the presentation, I'll be referring that to that link, and we can all kind of participate and kind of write up some of our thoughts on this disease. So I sent the link in the chat already, and then we'll refer to that in a sec. But otherwise, we'll get started.
Okay, everyone. So we have a 51-year-old male whose chief complaint is back pain that started 1 month ago. So with only this information, what are some questions like you guys want to ask?
And you can feel free to kind of just say it out loud and unmute, or you can type it in the chat, some preliminary questions.
What specific area of the back is hurt?
Okay, any other questions?
I would like to know more about his occupation. Does he do any heavy lifting?
I would also
Then,
like, no, pásale.
sorry, the intensity of the pain would also be useful, and if the pain gets worse or better at night.
Okay,
I'd
look-
like to know what happened when it first started hurting.
I think someone wrote in the chat the character of the pain as well. Great, so these are all great questions. We're gonna kind of continue with the HPI and hopefully have some answers for you guys.
So he presented to the ED because of back pain, specifically in the interscapular area with an initial intensity of 5 out of 10. It does not radiate, it worsens if he leans forward. And in the past week, the pain has worsened and increased in intensity to an 8 out of 10. He has taken Tylenol for 1 week without obtaining any relief. He denies dyspnea, hemoptysis, or night sweats, and he describes subjective fever. He also says that he has lost about 5 pounds unintentionally over the last month, and he attributes it to not being able to eat well because of his irregular work schedule.
So knowing this information, is there anything else? And we're going to kind of present the past medical history and things like that, but is there anything in kind of the review of systems that you guys would want to know as well?
Has the pain woken the patient at night?
Nope. There is no weakness associated. No history of trauma in the same area.
Any headaches?
No headaches.
Paresthesia, loss of sensation in the lower limbs specifically?
No, none of those symptoms.
We have some questions on kind of travel and animal exposure, which I don't think we have any information of, but you kind of prod a little bit more into his case and he tells you a little bit more information. And you find out that he has a productive cough with kind of a yellowish appearance in the past 2 months as well. So as we go on, we'll learn a little bit more about kind of his past medical history as well. So in terms of past medical history, really doesn't have any because he rarely kind of goes to the doctor. In terms of medications, likewise, he's not really taking any medications as well. Doesn't have any known family history that he can remember or reports. And in terms of his occupation, some of you asked about this. He is a truck driver and he regularly kind of drives between Mexico, Guatemala, and El Salvador on a pretty kind of daily, weekly basis. And that's what he's been doing, his occupation since like 20, 30 years ago. Some other kind of questions in terms of his social history as well. Smoking wise, he does smoke 1 pack of cigarettes daily for the past 20 years, but he does report that he stopped smoking around 5 years ago. In terms of sexual history, he's had 5 sexual partners in the past year. And in terms of allergies, no known allergies. So I just want to give you kind of like 30 seconds just to look over the HPI and some of the information that we have here. And once we're ready, we're going to move over to the Jamboard, the link in the chat that I provided, and we're going to kind of come up with some preliminary differential diagnoses. All right, so take like 15 more seconds to look at our descriptions here and make sure you have something in your mind. All right, so great. So this is a Jamboard. You can come here by just clicking into the link in the chat And how this operates is you can see kind of this like Post-it note on the left side of your toolbox. And if you just click on that Post-it note, you'll have something like this come up, and then you can type whatever you think your differential is and just save it. And then it'll pop up on the screen, and just make sure to drag your Post-it into a location where you see there's room. And it's completely fine if you see kind of what you thought the differential was already on there. Just put all the thoughts that you have, because we want to see the distribution of what everything, what people think it is. If you don't have the Jamboard, feel free to kind of write it in the chat, and then we'll help you put it into the Jamboard as well. Great, seeing lots of kind of great ideas. So I see some cancer, lots of TB, some HIV, spinal stenosis, some MSK, interesting spinal abscess. Great, great ideas. So let's take like another 10, 15 seconds. And as you're kind of coming up with this differential, I just want you to kind of have in your mind things that you would be looking for on physical exam or preliminary lab findings, which we're going to present next to you, to see if you can kind of either validate your differential or maybe move things up or down. But this is a great differential. We have lots of pulmonary disorders, we have some infectious disorders, MSK, we have some cancer here too. So very good job in making a broad differential. So let's go back. All right, so Dohan's going to continue.
So we have vitals, BP 120 over 75, heart rate of 125, respiratory rate 14, oxygen sat 98% at room air. We have a temperature 39.9 degrees Celsius, which is equivalent to 103.2 degrees Fahrenheit. In the physical exam, overall, the patient appeared slightly ill-appearing, wasted, but in no acute distress. HEENT, mouth was dry, no pharyngeal erythema or oral ulcers, no noticeable enlarged cervical lymph nodes. He was tachycardic, but no murmurs, no JVD, and respiratory examination revealed fine crackles, increased resonance of voice sounds, dullness and percussion in the upper third of the right hemithorax. Abdomen was soft, non-distended, no organomegaly. Neuro exam was normal. Extremity, there was no edema or joint abnormality, and no obvious skin rashes or petechiae. Also, there was local tenderness at T6 and T7 with mild kyphosis.
We're also going to give you some preliminary labs too, just some early labs that we draw.
Initial labs we had were a CBC with a white blood count in 5.1. Differentials were within normal limits, hemoglobin in 12.2, hematocrit in 37%, platelets in 130, ESR in 25, CRP 36, sodium 140, potassium 4, chloride 100, calcium 12, creatinine 0.8, BUN 16, glucose 77, ALT, AST, amylase, lipase are within normal limits. We have a blood culture that is pending and have a tuberculin test, which reported us 5 millimeters.
Great, so that we threw a lot of kind of additional information at you so far. So I'll just give everyone kind of 30 seconds to take a look at the physical exam and interpret the labs. And then I'll be calling on someone to kind of help me interpret what they see that's significant in the physical exam and labs. So let's take another 20 seconds. All right. Does any brave soul want to kind of unmute themselves and interpret what they found to be significant on this physical exam at labs?
Well, in the pulmonary exam, the fine crackles and the dullness in the percussion could orient us to a consolidation.
Great, great. That's a great interpretation. So we're thinking because there's some dullness on percussion, we have a consolidation in the upper third of the right side. Great. Anyone else or any other findings that you found significant?
The low fever or mid, the fever he has is significant. I also find it very interesting that despite the fever and the effusion, the cough, the productive cough, his white blood cell count is normal.
Yeah, that's a great observation. So he's, it seems like he has a fever, but interestingly enough, his white blood cell count is pretty normal. Great. Anything else? One other person.
So in this case, I agree with, I was just gonna say that, Jay, an elevated calcium. In this case, if we kind of bring the history, the physical exam together, we're thinking of two differential diagnoses here. Either a primary tumor of the spine, perhaps, specifically a multiple myeloma, or a small cell
Cancer, yeah.
lung cancer. Yeah, that secretes PTHR could be, and that can simulate these findings along with the findings in the lung and the thoracic spine.
Great, great. So I love the mention of kind of potentially like a paraneoplastic syndrome with the calcium kind of being high as well. Great. So let's just kind of go back very quickly to our Jamboard that we had originally. These were some of the things that we came up with in terms of our differential diagnosis. And now with kind of the additional information that I gave you, added all of these that we see here, can anyone kind of tell me either out loud or in the chat, what do we think is now out of this list? Is there anything that we want to add? And if you want to add it, just go ahead and add another Post-it note. Or what kind of rises to the top on our differential now?
I feel like we can rule out pneumonia because of his blood test results, especially he didn't have a very high white blood cell count.
Okay, great. So I'll just cross off on the pneumonias that I see. Great. Any other thoughts?
Hi, I want to add something. I'm thinking about an infectious disease, maybe HIV, because the patient work, he's a truck driver, so he drives a lot across borders. And here in Guatemala, that's a risk factor for HIV. He has an ill appearing, he has wasting syndrome, he has low fevers, he has weight loss and progressive cough, and that things and pancytopenia, a few pancytopenia, so that makes me think about HIV. So I would like more tests.
Great, great. So excellent. We're going to circle HIV. That kind of rises higher in our differential because of everything that you said. Great. Any other ideas? What else kind of might be higher on our differential now?
I think tuberculosis, because in Guatemala it's an endemic disease and the patient has productive cough. I don't remember if Dohan said that the cough was with blood stain, but it doesn't have to. So I think tuberculosis is a first differential diagnosis in Guatemala.
Great, excellent, excellent. I know we had a lot of kind of tuberculosis on here originally, so it seems to continue to be on the top of our differential. Great, great. So let's go back to.
I would like to know if this patient was received the vaccine, the Calmet-Guerin.
Gotcha. Dohan, do you know if this patient had the vaccine?
He received the BCG vaccine just as when he was like really young. So that's another information you should take into account for the PPD test.
Great. So going back to kind of our case again, and lots of people kind of talked about this already. What additional tests or imaging do we want to order? So right off the bat, I know someone said HIV. What other labs or imaging do we want?
Interferon gamma.
Great. Interferon gamma. Anything else? I see chest X-ray in the chat.
I would try to get a sample of the phlegm and do a gram and the mycobacterium stains.
Also, we would like a gene expert, the sputum gene expert. I agree with Sergi. Also, an HIV test, and if it's positive, a CD4 count and a viral load.
And about the sputum, I would also try to do a stain for fungus, because that's also something to take into account because of where he lives.
Great,
also,
great. And
would like we would like ideally would be good to have a 24-hour protein, like urine analysis for proteins, and also electrophoresis for proteins, but not the case. But we would like that.
MRI.
Yeah.
Great. And I see in the chat someone put MRI for the spine. Excellent. So we're going to present. So we have some of the findings here. We're going to assume that the other findings are pending by the time we're doing this case.
So the additional test we had was an ECG that reported only sinus tachycardia. Sputum samples were positive for acid-fast bacilli. Quantiferon test in sputum was negative. An HIV test was positive, and the CD4 counts were in 180 and a viral load in 2 million copies per cc. Also in the chest, the images, the chest X-ray revealed a cavitary lesion in the right lung apex. A cardiomediastinal contour was normal, an anterior wedging of T7 vertebral body, and a left paraspinal opacity. A thoracic spine MRI was done and reported a crush fracture at T7 with lithic lesions, with a left paraspinal septated fluid collection at the level of T6 to T8. There was no medullary compression. And also, finally, a gene expert, as many of you asked, was done. Gene expert MTV/RIF, which was positive.
Great. So now with all this extra information, and we don't have any additional labs and imaging, but with just this information that we have, plus our history and physical, does anyone want to take a stab at what we think this person might have?
On the top of my head, if he has tuberculosis, it can be Pott's disease.
Okay, great, great. And why do you say Pott's disease?
It's not a common complication, but the location where it's the pain, it's interscapular with a quantiferon, a positive quantiferon, a cavitary lesion of secondary tuberculosis that it's pathognomonic of this disease, makes me think that he has an active tuberculosis right now that it's complicating with probably multiple granulomas all over the lungs, and it's affecting already the spine.
Great, great, excellent idea. Great. So does anyone want to kind of explain just out loud to everyone in the chat too, why, if we think it's Pott's disease and tuberculosis, why the quantiferin test would be negative, and why the tuberculin test would be, so non-reactive at like 5 millimeters? Does anyone want to explain that?
In
That's
this
because of
case,
HIV. Patients debuting with HIV has immune allergy.
anergia.
I don't know if that's how you say it. I don't know. So that's why that test might be negative, the PPD, because patients cannot react. Their immune system cannot react to the PPD test.
Yeah, that's a great point. So you also have to take into account that when you do a PPD, the intervals are different depending on the risk factors of the patient. So normal patients, the normal values are less than 15 millimeters. If you are a healthcare worker, it's between 5 and 15. And in HIV, the threshold is much lower, like in this case.
Great. So, spot on. This is Pott's disease. In the interest of time, we're going to kind of give you our one-line summary on what we thought was most important and pertinent for this patient. So here it is. Oh, here we go. So this is, again, kind of to summarize this entire case together. This is a 51-year-old man with no past medical history due to loss of medical follow-up, presenting with subacute back pain, fever, and productive cough, with exam notable for right lung consolidation and local tenderness at T6, T7, found to be then HIV positive with positive acid fasting and gene expert, with a paraspinal fluid collection consistent with tuberous spondylitis, or the name for that, as someone said, was Pott's disease. Great, excellent job. So now we're just going to kind of very quickly go through some of our teaching points that we really wanted you to get out of this case. And the first thing that we wanted everyone to understand was kind of TB. When we think of TB, a lot of people think of kind of just the pulmonary manifestations, but TB also has a lot of extrapulmonary manifestations. And in this case, we have an example, Pott's disease. And in terms of epidemiology, we know that skeletal TB accounts for around anywhere from 10 to 35% of this extrapulmonary manifestations of TB. And the most common form is what we described here, Pott's disease or tuberous spondylitis. This patient is kind of a pretty good case for it, right? So it affects the lower kind of thoracic and upper lumbar regions, right? With this patient complaining of back pain. It's pretty like subacute and increases in severity over weeks to months. So it's not like a very acute kind of insult, but more progressive. And it's really just an infection and inflammation of the intervertebral joints and disc space, leading to this avascular necrosis, and finally, we also saw some kind of spinal compression. And the problem with a lot of Pott's disease patients is, people don't necessarily think of skeletal TB immediately when someone comes in with back pain. So prognosis is really dependent on how early it's caught, and how early kind of treatment starts. And we really wanted to get to another main point, which we wanted to ask was, does anyone know what the most important or potent risk factor for TB is? Any ideas? All right, so it's exactly within this case. It's TB with HIV. And we see it with this case here, right? A patient presents not only with TB, but also with HIV. And we saw how HIV can kind of alter the results for this patient in terms of his quantiferin, just because of kind of the CD4 count. All right, great. And the other thing that we wanted to really note here was that TB, in the United States, we don't see it a lot, but it really is the top infectious disease killer in the world. And if we look at this map, looking at kind of the new TB cases, the incidence of TB around the world, we see that in a lot of developing countries and countries excluding the US and parts of Europe, it's still very much prevalent within the world.
Oh,
And just
sorry,
some
David.
data.
We can't see your screen.
Oh, that's weird. Sorry, let me see. Okay, can you see it now?
Yeah.
Okay, great. I don't know what happened, sorry. But yeah, so as I was saying, as you can see on this map, you see that TB is still the top infectious disease killer in the world. We may not necessarily see it as much in the United States and Europe, but we see it still a lot in kind of developing countries. And the incidence, comparing USA and Guatemala, we have here, the incidence in the United States is 2.7 per 100,000. In Guatemala, it's a little bit more than 8 times greater at 25. And you can kind of compare the mortality rate and the percent of TB patients co-infected with HIV here as well. And I think, it's important to note that on the US side, we don't really see TB a lot in the hospital nowadays. And in terms of studying for board exams or whatever, a lot of the questions where the answer is TB is someone who is an immigrant from an endemic area, right? And those are kind of the keys that tell us that, okay, maybe we should consider TB. But and Dohan's going to kind of tell us a little bit more about the TB situation in Guatemala and how kind of that affects their differential diagnosis thinking as well.
Yeah, and I also wanted to ask, to the audience, if someone from Guatemala tell us their experience of TB in the hospital, how common is it, or is it always on your differential, or?
Hi. Right now, I'm doing an elective in infectology here in Guatemala, and we see tuberculosis every day. Maybe 2-3 patients debuting with tuberculosis and HIV. So it's really, really common.
Yeah, I think I share Sergey's experience. It's really common here in Guatemala, and it's almost in your top differential diagnosis in most of the times. So
also, we had a lot of, well, at least I had 2 patients with fever of unknown origin that turned out to be tuberculosis. That's a common differential, as Dohan said. And also in our surgical clerkship, specifically the thorax unit, most of the pleural effusions, I would say most of them, are due to tuberculosis.
Interesting. I mean, I think all of these examples just point to kind of the difference in differential diagnosis and clinical reasoning just based on disease prevalence and incidence between kind of the US and Guatemala. So super, super interesting examples. We just want to kind of bring back our 3 teaching points that we had for you for today. So the first one, we wanted you to identify extrapulmonary manifestations and risk factors of TB within the bone and joint space, so specifically Pott's disease. Number 2, we wanted to describe the effects of HIV on differential diagnosis and diagnostic tests for TB, which a lot of you kind of astutely mentioned during our presentation. And 3, we wanted to kind of share and compare the incidence of TB in the US and Guatemala and explain how that really affects our clinical reasoning when we're looking at patients and coming up with differential diagnoses. But yeah, and our last slide that we have, we kind of just have the entire case presentation here again, and we highlighted what we thought were the important parts in red. But yeah, thanks everyone for listening and sharing their thoughts.
Wonderful. Well, I will present our next group. So everyone, my name is Sebastian Guali. I'm a 4th year at Penn applying to pediatrics, and I had the honor of working with Majo. Will you please present yourself and our distinguished guest?
Hi, my name is Maria Jose. I'm a last year student here at UFM. And I wanted also to present Dr. Carla Ramirez. She's one of our teachers here at UFM, a great teacher, and she's also a pediatric surgeon who will be joining us today if you have any doubts, so she can help.
Unfortunately, it's just not a surgical case, so there's no spoilers here. So we'll figure out what kind of comes up. And then also, of course, Jay, would you like to introduce yourself real quick because you are a key part of our team?
Hi, I'm Jay, also a 4th year. Also Penn, also very happy to be here. I'll just be in the background controlling the slideshow. This is all them.
Excellent, excellent.
Okay, so while we put up the slides, I want you to face this case as if you're a doctor on call on the ER. And they call you because you got a new patient. So here's your patient. Okay, we have a 5-year-old male. He's a son of unmarried parents, born and raised in Guatemala City. The main complaint is stomach bloating of 3 weeks. And basically the mother says that a week ago, the patient's chronic abdominal bloating started increasing. It didn't go down by itself. So she decided to go to the ED. Anything else you want to know at this point? Any questions you will want to ask? Or
does anybody have a great way of approaching kind of the first, set of questions we want to ask for abdominal bloating? I am not afraid to call on people. Let's see. In the chat, I see, is there any pain? Is there any gastrointestinal sounds?
Okay, well, pain and sounds, we'll face it in the physical examination, but nausea and vomiting, no.
Okay, excellent. Let's see. Let's get somebody else from
Okay.
UFM to ask. What other questions? Let's see.
Change distance tool. Okay, Jay, can you click next, please? This is what we have. The patient is feeding correctly, bowel movements. I mean, he's pooping 4 to 5 times a day. And it's usually liquid or gel-like. The mother also says he poops like a bunny every once in a while. There's no vomiting. And this patient suffers from chronic abdominal distension. This changes cyclically up and down. So this is weird because it didn't stop. And this has only happened once before, and it was due to fecal infectation, which was released manually. Okay, a specific food that worsened it? No, not water. And the patient is defecating as the mother expected, like liquid, gel-like, or like a bunny sometimes. No blood. Water consumption, we don't have any specific detail about water. We just know the patient is feeding like he usually does at home. Okay, any other questions? Okay, let's keep going. We have his past medical history. The mother remembers some things and doesn't remember other stuff. So he's a product of a second pregnancy at a gestational age of 38 weeks. Low amniotic fluid and forceps were used during delivery. And there was no spontaneous crying. Growth and development is normal. Medical, the mother says they told her he had perinatal asphyxia and he had some milk allergy, but with no specifications. His immunization is up to date. In past surgical history, he had an exploratory laparotomy at 19 days old due to suspected intestinal obstruction. And in April 2018, he had a release of adhesions and appendectomy. Family and allergy history are non-contributory. Okay, does any of the family have similar symptoms? Not that the mother says anything, she's here just because of him. Okay, we can have intussusception. Did they find anything during the X-lab? We actually don't have that results because that's just what the mother says. I mean, she knows he went into surgery for an X-lab, but that's all. Okay. If we take the physical exam, he has a heart rate of 115 beats per minute, a respiratory rate of 40, BP in 115/77, temperature 37 degrees Celsius, and which is a 98.6 degrees Fahrenheit, and a fat at 98%. The patient is awake and alert, but he looks like chronically ill and cachectic. He has a nasogastric tube that's draining fecal material. Head nose and throat, no significant findings. His thorax is reduced due to abdominal extension, but he has symmetric extension with good breathing sounds bilaterally. Heart is normal with heart sounds, no murmurs. And the abdomen is bloated, shiny, and with visible collateral circulation due to stretched skin. He has 2 visible scars, a transverse scar that's approximately 10 centimeters in length on the right side of the abdomen, and 1 5 centimeter in length in the left iliac fossa. He has decreased bowel sounds. It's not tender, but it's really tense at palpation, and it has a circumference of 80 centimeters. We have no pitting edema in both lower extremities and no focal neurological defects. Okay, let's just see the question. If the obstruction was confirmed, the mother doesn't remember. Change in mental status, not a physical exam. The patient's a normal 5-year-old. Percussion, it's completely hyperresonant. And I want you to look at it. Basically, it's pretty outstanding. So, would you please? Okay, so this is our abdomen. I mean, and you can see the abdomen, as I told you, the collateral circulation, both scars, and look at his arms. I mean, he's basically extremely, extremely thin. Yeah, and obstruction is something we have to take into account. Anything else? Okay, so right now,
one of the things I think in the ED that we think about a lot is you walk into the patient room and I have to know sick or not sick. Is this someone that I'm worried about? What do we think? Yes, I hear in the chat. But it's been going on for weeks. Why are you worried?
I think I would be worried for any perforation if the patient is draining fecal material in the nasogastric tube.
Mm-hmm.
Actually, we don't know if placing the nasogastric tube relieves some abdominal pressure because the moment we saw him, he already had it. So we don't know how he was before it. But if we keep going, at this point, with the physical exam, with medical history, what will be your differential diagnosis? Someone said intussusception up here. GI obstruction? Yeah, but why? Yes, a rectal digital examination was performed and it didn't help. Parasites?
Well, he already had adhesions, so perhaps it's a second episode.
Yeah, that's really important. He had 2 surgeries before, so that's something we need to take into account. Okay, we keep going. So right now we have adhesions due to surgery, GI obstruction basically, roundworms, parasites, volvulus, a Wilms tumor, important. Hirschsprung disease, remember this is a 5-year-old, but it could be. Okay, next. Okay, so now the left. What do you want? Because all we got is a complete blood count, blood chemistry test, and crack studies. Anything else you want to add or would like to add? We don't have height, so we don't know if he's small for his age. We only know he's thin. Okay, can we show the left, please? The complete blood count, we have a white blood cell at 7.5, neutral at 25%, hemoglobin at 12.46, hematocrit at 37.9, and platelets at 539.30. The crack studies are between normal ranges. At blood chemistry test, we have a creatinine of 0.13, blood urea nitrogen at 9, glucose at 18, calcium at 8.4, chloride at 112, potassium 3.9, magnesium 1.84, sodium 138, phosphorus at 3.2, ammonium at 34, albumin at 2.4, and C-reactive protein at 23.69. We don't have pancreatic enzymes available. No blood gases. Okay, do anyone want to comment on this lab?
I think it might be important to discard cystic fibrosis because of his chloride levels, and the obstructions could be because he had it before as well, and he's also very skinny, so that they also have nutritional problems.
Yeah, it could be. That's really important, actually. Just remember that we have clear breast sounds, both sides. So that would be a different diagnosis. And okay, if I ask you, what images do you want? Okay. Anything else? Or just the abdomen? X-ray.
What's a USG for my learning?
Ultrasound.
Ah, okay. And what are we looking for with an ultrasound? What do you want to see when you put the probe on the belly?
I'm not sure.
Yeah, it's okay. I don't think I'd be sure. It's a big belly. Let's see. Even if it's a 5-year-old, I think it's justified to rate him with a CT scan. Okay. Right. I mean, I know that if he was at our children's hospital, he'd immediately be getting a CT as soon as he walks in. So that was the first thing I think I'm thinking with in terms of imaging.
Okay, so if we keep going, actually we had a problem with the CT because his mother decided he didn't want him sedated. So the only thing we could get was the X-ray, and you'll see it now.
Alrighty, let's get, I'm gonna call on my friend Laura to read this abdominal X-ray because I know she was on. So Laura, my neuro friend, Laura, hand on this. How would you read this X-ray?
I'm definitely no expert on abdominal X-rays, but it does look, with abdominal X-rays, I would start, I guess, by looking if there's any air collections where there shouldn't be any.
Mm-hmm.
So not in the intestinal tract. That I don't in particular see. And then I just look at the size of the GI tract, and I try to determine whether I'm looking at small intestine versus large intestine. And then depending on where I am, I try to determine if the width for that location is too wide. This looks big to me. It looks like there's some backup or slow transit through the GI tract just by like gestalt of like looking at the width.
Okay, I like that.
Yes, I don't know if what we're seeing on the X-ray is the coffee bean sign. On the previous one, I think it was. Yeah. So with that, I would be thinking about volvulus as a cause of that.
Okay. So right now, after the images, after the lab, Sergi just said volvulus. And okay, can we think of any other differential diagnosis?
Is there anything infectious that would cause a colon that big? Oh, I think Sergi, what causes megacolon?
Clostridium difficile can cause megacolon. Maybe, I don't know, like in the pediatrics case, I don't know if it's that frequent, but in adult patients, it would definitely be a possibility.
I think Chagas disease also manifests sometimes with a toxic megacolon.
Excelente. Yeah, I think those are the two that at least I had in my mind when I think what other infectious possibilities could cause a megacolon.
What about parasite? Maybe histolytic and histolítica. I don't know how
Sí.
it's
En inglés se dice histolítica.
Oh, you were right.
Yeah, it's histolítica. Yeah. the fun part of this, I love this.
I'm sorry.
Muy bien.
Okay, Jay, can we keep going? Okay, and at this point, you contacted his usual doctor, and we got a lot of new information because the mother doesn't remember everything. So we have something new. Next click. Okay, yeah, he had an X-lab at 19 days old. He also had a Duhamel procedure in February 2018. And in PATH, we got an stenotic colon without neural somas, or an agangliotic colon. We have an X-lab and an anastomosis remodeling at March 2018, a surgical lavage plus a pain-rose drainage at March 2018, and a new X-lab and a release of adhesions plus the appendectomy at May 2018. So right now, does anyone know the diagnosis?
If he had a
Well, he's obstructed.
Yeah, perfect. That's what we have. We have a history of Hirschsprung's disease.
If I'm not mistaken, I mean, maybe Dr. Ramirez can verify that. I think sometimes Duhamel's procedures can miss part of the Hirschsprung's when they dissect it, and that can leave you with some kind of incomplete Hirschsprung later on. I'm not sure. I don't know if it was Duhamel or another procedure, but one of those procedures, if not done properly, can leave the patient with partial, would say partial resection, and keep the aganglionic part of the intestine.
Hello. Yeah, that's a really good thought. I mean, most of the patients, I mean, in any of the procedure that you choose, I mean, any of the surgical procedures that you choose, you can leave part of the intestine with an aganglionic part. And that's one of the worst complications that we can have. Actually, the two procedures that we choose to do now, it's the laparoscopic one, because we are able to take biopsies during the surgical procedure. So we are not taking any colon that has still the disease to put it down and do the anastomosis. So that's something really important to do. And if we are able to do the biopsies during the procedure, we are able to make a really good improvement in the next days of the surgery. This patient, with all the surgeries that he had, I think they might miss the thought of Hirschsprung disease as the first time they did the laparotomy. When you have a baby that it's only 19 years old, you have to think of all the different diagnoses that could cause an obstruction in the neonatal time of any baby. So one of the diagnosis that is more difficult to do is Hirschsprung disease. These babies will have enterocolitis, so that's the megacolon of the adult patients that you have to think about. And the patients would be just like the picture that Maria Jose just showed. It's a patient who has been sick for 5 years. I mean, his whole life he has been in and out the hospital with different surgeries. And the more surgeries this patient have, he will have more complications. I think you said that he has a colostomy now.
Yeah, that's where we're gonna end. If we can keep going, we have basically we had a diagnosis of Hirschsprung disease at 4 months old. So now basically we have a problem of extensional obstruction. As you said, adhesions is still a main problem, obstruction of the anastomosis. And we really hadn't thought about the leaving a piece of the Hirschsprung embryonic column, but that's also important. So as the doctor said, we have a case resolution. This patient was taken to the OR for another X-lab, and the findings, we have a stenosis of the distal anastomosis, multiple adhesions, and dilated intestinal loops filled with fecal material. They did a complete anorectal exploration, anal dilations, the exploratory laparotomy, and this patient had to go into a double barrel colostomy. So yeah, he could release all the fecal material he was holding because it was impossible to release the anastomosis at this point. So right now, I want you to think what you can learn in this case. And that's the reason we presented it the way we did. Because if you saw, you came up with all these differential diagnoses before really knowing what he had. So Sebastian will help me here.
Yeah, and so for our teaching points, I think the things that are really important that I got from this case when Majo first presented it, right? The first part is really just actively widening your differential, right? I mean, for me, a 5-year-old with abdominal pain, if I'm not thinking about what could have happened back then, right, which would have led me to Hirschsprung's, you miss it, right? And so, oh yeah, Anna, super great point. And Jay was actually of similar thinking that Hirschsprung can be syndromic. So looking at, normal facies and other kind of features is really important, right? But if we don't look, we'll miss it, right? I mean, if we see a kid like this and we automatically zoom in and say it's just a perforation or it's, we'll miss any other different diagnosis that could be right in front of us. I thought it was really nice how we used our lab findings to help paint a picture of the etiology. So we see someone who's been malnourished and kind of, I think it's really important in cases to not only know what questions I want to ask and why, so what answer pushes me one way or the other, but then using those labs to help kind of fill in the gaps. And then another teaching point for myself was that and Ibrahim, you did a really great job of this, of kind of having a base knowledge of surgical procedures for basic pediatric illness, right? If we're for those who are gonna be pediatras in the future, right? Those who are gonna take care of kids, knowing what are the common surgeries that they undergo, what are the common complications, because we're gonna take care of these kids for the rest of their life. And so just being mindful of that, I think was really important in this case. Something specifically more for us gringos is you don't always need a CT scan to diagnose an obstruction. I mean, we rely so heavily, you'll see in our hospitals, on CTs and MRIs. And so using the clinical context and a good X-ray can get us there. And then last, and an important teaching point is Majo's a rock star. You know, this has been a fun presentation. I appreciate everyone's participation, even if I was scary and calling people out loud. So any questions or thoughts, I guess, about the case?
I just want to say that all the differential diagnoses that you were mentioned are really, I mean, good thoughts. I think you, it was all of them. I mean, you can have intussusception in this kind of childs. It will come more if there's a baby who is only 1 or 2 years old. It's a different time of not a 5-year-old, but this baby looks really sick. I mean, you have to think that it's a baby that has been, it's not an obstruction that has 3 days or a week. It's a baby that has been sick for a long time. So that's something you have to keep in mind. And maybe the mother will not give all the information that you need, but you have to only look at the baby and see, is this something that just had been happening for a few days or a week, or this baby is not normal for his age? That's something good too. Other differential diagnosis that you were thinking about, I mean, parasites we do see a lot of children who have obstruction because of parasites in Guatemala. I mean, you would think that you don't see this in the city, but we still do, and children will look just like this. They have been under really bad conditions. They don't have a normal growth. So our babies who maybe are 5, 6 years old and they look like they are only 2 years old. That's a really good thought of a differential diagnosis. Cystic fibrosis too, but he will have more episodes of being sick before. And bulbous, that's a really good thought too. And this child, because of the Duhamel procedure, he will have an internal hernia too. That's another differential diagnosis that you have to think about with a baby who has had different surgeries before. So I think you did a really good thinking of differential diagnosis in this case. It was really well presented too.
Thank you very much, and thank you everyone for their participation. And thank you, Dr. Ramirez, for being here and for helping us with all of this. It was a lot of doubts on surgery.
Well, is that wrapping it up, Andy?
Yes, I think so. These presentations were phenomenal. So thank you to all the students.
You got to read my comment, because there was this TV show we get in the United States called The Good Doctor. It's this autistic, I don't know, it's this stupid show. I don't know why I watched it, but anyway, there was an adult patient that had Hirschsprung's, and he had it because he got a stem cell transplant with a CRISPR technology. And so essentially he had a pediatric disease even as an adult. Not to overcomplicate your lives as you go forward in your careers, but so I had guessed that one on that one right away. But only because I watch too much TV. Listen, you guys are absolutely awesome. I got to tell you, I really enjoyed listening. And I did miss the HIV one, as I mentioned in the chat, even though I'm an HIV researcher. So I probably should have gotten that one. So look, if everybody had fun doing this, you guys at UFM, please let Dr. Martinez know. We'll catch up with, of course, all the people at Penn, because I think, you know, there's something to be gained by this, doing it, not all the time, but every once in a while we get together. I hope very much that when international travel is allowed for more for our students, which my guess will probably start happening summer, certainly by the fall. I hope those of you at UFM who are still there and haven't graduated at that point can come up and visit us at Penn. If you're still there and you want to do it, please let Dr. Sergio know, and I'd be happy to, Andy and I'd be happy to arrange that so you can come up and do a clinical rotation at Penn. And certainly for all the Penn folks, you know, we do occasionally do rotations down in Guatemala as well. So please talk to Andy about that. And again, I think for most of us, we're hoping this summer, but if not this summer, well, if not the early summer, probably a late summer, certainly by fall, we'll be back in the swing of rotation. So thanks very much, everyone, for all of your participation and hard work. I know this was a lot of work to put it together, especially for the presenters.
It was such a joy. Colegas de Guatemala, muchísimas gracias por estar con nosotros otra vez. Voy a poner mi mail en el chat si quieren platicar o conocerlos más o conectarnos de alguna forma o manera en el futuro. Siempre feliz de colaborar con ustedes, ¿ok?
Thank you.
All right. Bye-bye, everybody. Have a good night.
Bye-bye.